Alzheimer's disease. This is the most common cause for dementia in the elderly. This disease usually starts as insidious loss of episodic memory, which is followed by slowly progressing dementia. And the disease usually starts in the medial temporal lobe and then spreads to the other parts of the brain. That is, the brain will undergo atrophy. Microscopically, there will be neurotic plaques and neurofibrillary tangles and A beta 42 deposition in the vessel walls. And one of the major risk factor for development of Alzheimer's disease is the E4 allele in the ApoE gene, which confers 2 to 16 times the risk for developing Alzheimer's disease. Clinical manifestation, it starts with memory impairment. So the patient first will present to us with memory impairment, which will be followed by language deficit, visual spatial defects, and loss of executive functions. That's a terminology called minimal cognitive impairment, which is nothing but a drop in the memory level, that is 1.5 times the standard level below that for that age group. And the patient will have anosognosia, that is, patient will be unaware of his difficulties, and any change in the environment will destabilize the patient, that is, the symptoms will get aggravated if the patients are taken to a newer places. In the middle stage, apraxia ensues. Apraxia is nothing but inability to do learned motor activities in the presence of normal motor functions and sensory functions. And language then gets impaired and visuospatial defects also starts. Later the patient will develop delusions, sleep disorders and disinhibitions. In the end stage, the patient will become mute, rigid, akinetic and will develop urinary incontinence. And the death in this patient is usually due to pulmonary embolism, aspiration pneumonitis and cerebrovascular diseases. Differential diagnosis always low treatable causes like primary and secondary neoplasms, vascular dementia, diffuse white matter disease, normal pressure hydrocephalus, which has a triad of urinary incontinence, gait apraxia and memory disturbances. And Alzheimer's disease predominantly affects the posterior part of the brain. Hence, PET scan will show hypometabolism in the posterior part and medial temporal lobe. The PET can also differentiate amyloid fibrils. These are the differential diagnosis. When the patient presents with yearly gait disturbances, that is, the patient will present us with gait disturbances rather than the memory disturbances, the differential diagnosis should be vascular dementia and normal pressure hydrocephalus. When the patient has resting tremor, stooped posture and bradykinesia, it is Parkinsonism or dementia with Lewy bodies. And the patient has Parkinson disease-like features with visual hallucination and delusion, think of dementia with Lewy bodies. And the patient is a chronic alcoholic, think of some vitamin deficiency in the form of vitamin B1. Vegetarian, think of vitamin B12 deficiency, because these are treatable causes, reversible causes of dementia. Seizures, when the patient is present to us with seizures and dementia, think of primary or secondary malignancies. When the dementia is very rapidly progressing and is also associated with rigidity and myoclonic jerks, think of Creutzfeldt-Jakob disease. When the patient has prominent behavioral disturbances with the frontal atrophy, think of frontotemporal dementia. Frontotemporal dementia, as the name indicates, there will be frontal, that is, the anterior part of the brain will get involved, whereas Alzheimer's disease, it is of posterior brain. There is a terminology called prodromal AD, that is, patient will be asymptomatic, and these patients will have decreased A beta 42 in the CSF and postpartum tau will be mildly increased in the CSF. Alzheimer's disease, this is what is given in Harrison. It is a slowly progressive decline in the memory and orientation. Normal results on laboratory test and MRI and CT scan showing only distributed or posteriorly predominant cortical and hippocampal atrophy are highly suggestive of Alzheimer's disease. So it is a disease affecting the posterior brain. Age risk factors. Age is the most common risk factor. Patient more than 70 years, 70% will have Alzheimer's disease, can develop Alzheimer's disease, and family history is one of the strong risk factor. Apart from this, female sex, history of head injury, diabetes, hypertension, dyslipidemia, elevated uric acid, decreased exercises, and elevated homocysteine and decreased intake of fruits and vegetables also are considered as risk factors for development of Alzheimer's disease. Pathology. Atrophy is seen in the medial temporal lobe, infralateral temporal, and nucleus basalis of Mayer net. Microscopic finding, as we said, there will be neurotic plaques and neurofibrillary tangles. There's a protein called amyloid precursor protein. This protein, amyloid precursor protein. This protein, when it is cleaved by beta secretase and followed by gamma secretase, we develop a toxic product that is called as A beta 42. This is a toxic product. When the same amyloid precursor protein is cleaved by first by beta secretase followed by alpha secretase, it results in non-toxic. So beta secretase followed by gamma secretase will result in development of A beta 42, which gets deposited in the brain. Normally, the function of amyloid precursor protein is neuroprotective and neurotropic. It promotes the growth of the neurons. When this gets cleaved by beta secretase and gamma secretase, the patient develops Alzheimer's disease. Tau, we said neurofibrillary tangles are nothing but hyperphosphorylated tau proteins. Tau normally helps in the transport of the organelles in the neurons from the axon down from the cell body down the axons, and also stabilizes the microtubules. When this gets hyperphosphorylated, their function is lost. Neurofibrillary tangles are composed of these hyperphosphorylated tau proteins, which cannot do its function because of the hyperphosphorylation. Biochemically, Alzheimer's disease is characterized by decreased level of acetylcholine. So, any drug that increases the level of acetylcholine in the nerve terminals can give us symptomatic relief. Coming to the genes, these are the genes commonly implicated in the development of Alzheimer's disease. It is chromosome 1, chromosome 14, 19 and 21. Presenilin 1 and 2 are important in this aspect. Presenilin 1 is on chromosome 14, presenilin 2 is in chromosome 1. And ApoE4, as we said, is one of the strongest risk factor. It is on chromosome 19, and Down syndrome, chromosome 21. And it also encodes for the amyloid precursor protein. So, mutation in this can cause Alzheimer's disease. Treatment, it is usually supportive cholinesterase inhibitors. That is a drug which decreases the destruction of acetylcholine in the nerve terminals. Like rivastigmine, donepezil, galantamine are useful, and NMDA glutamate receptor antagonists like memantine can be used. HMG-CoA reductase inhibitors have been found to be useful, and vaccination against A beta 42, because that is the main culprit. So vaccination against A beta 42 can also be useful.